Can everybody hear and see me? If you can hear me, at the very least, if you can just chat a yes in the chat box so I know that we're good to go. Okay, good. Welcome. We today are talking about a culture of learning in sexual assault services. And we're so excited that you're here. So today we're going to start with introductions, talk about what a learning culture is, and talk about good data, and then give some examples from our experience at the Safe Alliance. Feel free to ask questions throughout. You can do that by typing in the chat. It may be hard for me and Sydney to catch your questions as we're going through, so Maya may jump in at various points to make sure we get to your questions, and then we'll also have time at the end for questions, and then we'll end with something called 15% solutions, which hopefully will help you leave with some takeaways about what you can bring back to your organizations. So, we'll start with introduction. So, my name is Ashley Juraska. I work for the Safe Alliance. SAFE stands for Stop Abuse for Everyone. We're based in Austin, Texas, and I'll talk about SAFE a little bit more in a minute. And my role is I'm the Senior Director of Data, Evaluation, and Information Technology, so I wear a lot of hats. But I am really excited about the data and evaluation piece and talking about that with you today, because I do think that data and evaluation can transform our work and help make sure we're giving the best possible services to clients. And I got involved first in this work, actually not through data and evaluation, but as a sexual assault advocate. So it's definitely something that's very close to my heart. So, and I'm going to turn so we can hopefully see Sydney. So, maybe.
Hi, y'all. My name is Sydney Kipp, and I am the Sexual Assault Response and Resource Team Coordinator. But I'm also one of the full-time staff that supports our sexual assault advocates, both the volunteer and the staff. So I'm really here to kind of give a program perspective on how we are evaluating and what that looks like when we're working with survivors. I first got into this advocacy work when I graduated college in 2014. So yeah, but I'm also a big data and evaluation nurse. I'm really happy to be here with Ashley and us presenting and talking to you guys.
Cool. So I'll take it back over and just give a quick overview of SAFE. So we serve survivors of sexual assault and exploitation, domestic violence, child abuse, and human trafficking. We have a ton of different programs. We have shelter programs, both for families and individuals who are escaping various forms of violence. And we also have a children's shelter. We have prevention programs in schools and community education. And then, of course, today we're here to talk about our sexual assault services. And our sexual assault services include both sexual assault advocacy, and we have an on-site forensic clinic, and we have nurses that work for SAFE who perform forensic exams and give consultations and offer healthcare services in the aftermath of sexual assault. Anything you'd add?
No, we, along with the forensic nurses, we do have an advocacy department, and that is comprised of both volunteers and staff that have to go through an intense 40-hour training, and their role is to really just like meet with the survivor and give them all the information they need on the advocacy end, what they're experiencing going forward, and really just sit and hold space with them in a really traumatic time. So that's kind of the part that I work with.
Perfect. Thanks, Sydney. All right, so before we jump back more into some of the specifics of what we've been doing, I wanted to make sure we started off with some general definitions so you understand how we think about learning culture and good data. So starting with a learning culture, I like this cartoon because basically a learning culture is that you learn and you learn and you learn and you learn. So the first sort of general principle is that learning is an explicit part of every conversation. So we'll talk a little bit more in a minute about how we have nurses be briefed in a session. We get feedback from our advocates. So we try, but don't always succeed, and that's one thing I want to say up front. We have not got this all figured out, so just know that this has been a learning process, but that's kind of the point, is that we keep learning, and we're still learning. Everybody, ideally in a learning culture, would be responsible for learning, so the advocate is responsible for learning. Maybe something doesn't go as great in the interaction with the survivor, and so they debrief with somebody like Sydney and talk about what could go better, what maybe could be done differently in the future. And then the nurse is also talking about that. And then our senior director of sexual assault services is thinking through, how can we do this, run this program better, and so on and so forth. So ideally, everybody's a part of that conversation. And even facilities is involved in how can we think about how to set this up better so it's more accessible and things like that. I also really like this one, though I don't like this one, right? Because having a culture of failing forward is both liberating and terrifying, because none of us like to fail. But what's liberating about it is the idea that when we do have things that don't go well, we're failing forward, so we're learning from it. So it's not just something that we feel shame about, but we actually feel like, okay, I didn't really like that I didn't do that perfectly, but here's a lesson I can learn from that. Or if our data are telling us that something's not going quite as well as we had hoped, hopefully we're really learning from that. And then also we're trying to examine our biases. It's really hard to know, especially when we come from backgrounds that may be more privileged. It can be really hard to even know what our biases are, but trying to understand where our biases may be, and Sydney will talk in a little bit about how some of our data might be biased, but really trying to have that be an explicit part of the conversation. And then I think biggest of all is that we actually take action based off the learning. So it's not just here's the data, but there's an actual action tied to it. And all of these things are ideals. Again, nobody's perfect, or as Pam on The Office said, nobody's perfect. But these are things that in an ideal world would help us make sure we're giving the best possible service to survivors. And then I'll move on to good data. So a colleague of mine, Ellie Copeland, who's on the steering committee with an organization called Good Measure, came up with this definition, and I really like it. And she talks about how good data is used. So basically, and this cartoon kind of gets to it, and the cartoon says, look at all this data. And then the person says, yeah, but what does it all mean? You can have a lot of data, but not have a lot of meaning. So we want to make sure that we're collecting data that's meaningful, but also that we're using as well, and we're reflecting on. We also want to make sure it's reflective of the client experience. So we want to make sure that what we're collecting is true to what the client is experiencing as best it can be. And that can be a challenge when we're working with people who are experiencing trauma. We also want to make sure, I'm going to actually skip down, that good data is credible. And part of being credible is that it is accurate to the experience that someone is having, but also that we're not explaining it away. So if we're giving data credibility, we're not saying, oh, this person said this, but we don't think that's really true. So we want to make sure we're really taking a hard look at data, even when it might not be something that we want to see. And then good data is also right-sized. So I think one of the handouts that should hopefully be in the materials, oh yeah, I do see the materials now, and it looks like it is. It's called the tiers. And that resource is really nice because it breaks down sort of the different levels of data collection and evaluation within an organization. And I think it does a really nice job showing how the more rigorous of data collection and evaluation you're doing. So if you're doing, for example, a randomized control trial, which I would generally not recommend for this work, and I'll get into that later, but if you're doing something like that, that requires a lot more money, a lot more staff time, and a lot more resources in general. And so really thinking about what's appropriate to do when, and when things are just not appropriate to do. So we want to make sure that we're collecting appropriate data at appropriate times. Cool. And just a reminder to anybody who is joining us after we started, feel free to chat any questions as we go through into the chat box. So I wanted to give just a little bit more about our program. So again, we have a sexual assault services program, and as Sydney mentioned, that includes both advocacy, which actually has been happening at our agency since the 70s. So we have a long track record of sending advocates to hospitals and other places where forensic exams occur. In 2015, we started a program where we have on-site forensic nursing. And so what you're seeing on the screen right now is what we fondly call Eloise House. There's now actually, you can't see it on the screen, but there's now actually an Eloise House 2 behind this. So we have a total of 4 rooms where exams can be conducted. And yes, there are times where all of those rooms are full. And what's really nice that we found about this is that the wait times are significantly reduced from having to wait in an emergency room. And all of our nurses are hired by us, and all of our advocates are hired or volunteer with us. So we have a little bit more control over some of the quality of the interaction and how trauma-informed our response to them is. And we do still do forensic exams in hospitals. So one thing that's really important to know about our on-site is that survivors do not receive a bill for the services. So as those of you know who deal with this in your programs, when people go to hospitals, they can end up with big bills. And even though there's crime victims compensation, sometimes people don't understand how to apply for that, or they may not get everything covered. So we found that it's nice to not have a bill. And one thing that is a concern that I've heard before that I just want to address is that we do make sure that if somebody has medical needs that go beyond what we would be able to offer in this offsite clinic, they are getting served in hospital situations where it's more appropriate to serve them. So there is a rigorous process to make sure that we're serving people who for whom an offsite forensic exam is appropriate. Anything you'd add, Sydney?
No, that really covers the scope of what we do. Pretty beautifully.
Oh, thanks. Okay. All right. So moving on, we're going to start going through some of the ways that we collect data and feedback. So I'm going to pass it off to Sydney to talk about how we collect feedback from advocates.
Sure. So after every time that an advocate is meeting with a survivor, we refer to that as accompaniment. So so you know, when I say accompaniment, that means that we are meeting with survivors, whether that be with a forensic nurse, without, depending on the survivor's needs. So advocates are asked at the end of every single accompaniment, once the survivor is gone and they've finished all the things that they're supposed to do, to go and complete a survey that's really about the entire accompaniment, how they did, any feedback about the forensic nurse, and any feedback about the interaction with the survivors, as well as policy and practice as a whole. So what we do, just to make it super convenient, because obviously they've been through a really, really long accompaniment with a survivor, it can be very emotionally high intensity. So we just want to make it as easy for them as possible. So we've linked the survey on our Chromebooks. So they go in, they pull up the survey, and after every accompaniment, they fill out all of these different data fields. So what we're really looking for when we ask them to complete this, we're first looking for how the accompaniment went, how the advocate feels like they did. Do they feel like they covered everything that they're asked to cover? How do they feel that the interaction with the survivor went? We're also really asking them as they go through this to be mindful and kind of process their accompaniment. It's hard to not kind of put it all out there before going home, so it kind of gives them that space to debrief as well. We're looking for if they are constantly missing things, we need to look at ourselves and use that data to formulate how we're going to look at our trainings and revamp our trainings. We also look not just so much about if things are being missed in the accompaniment, but if there's something that we're seeing with the target population that's coming up over and over again that we haven't seen before and we need to kind of tweak our policy, we're looking at that, and that really gives the advocate voice in that to kind of let us be aware of this. We always try, if the advocates forget to fill this out, because obviously it's a very long process and they've spent hours in the clinic or they've been in a hospital, it's been really draining, we try to follow up with them within a business day just to give them that space of like, hey, if you could fill this out, we really want to make sure that we are tracking all of this. And it's usually done pretty well. Obviously, people just forget, but we want to make sure that we're getting data for every single survivor that we see when it is trauma-informed and appropriate. And I think that's really it for our feedback on advocates. Okay, I'll turn it back over to you.
Cool. All right, so I'm going to talk a little bit about some of the responses that we've gotten from advocates. And one thing to say is that 90% of advocates stated that they were satisfied with how the accompaniment went, which as somebody who's been an advocate, I think that's great because I know I definitely had a lot of times where I didn't feel totally satisfied. But where we really find a lot of value is in the feedback where things didn't go as well. So 10% were not satisfied with how the accompaniment went. And they stated many reasons, and I think these reasons will probably resonate with those of you who do accompaniment or have advocates who do accompaniment. So they included things like, I feel like I could have done more, horrible treatment of the survivor. I feel like I couldn't do enough for the survivor because I couldn't get her into a shelter. I wanted to give her more resources, right? We never have enough resources to give. And not sure I made a difference. And all of those are valuable for different reasons. So not sure I made a difference. That's one that Sydney or somebody else on the team could follow up and just really talk through, why were you feeling that way, and kind of help point out the ways in which we do make a difference even when we don't feel that way, because hopefully we're being trauma informed for not only our clients but also our staff and volunteers, and that might be a sign that somebody's either new in the process and not sure the ways in which we make a difference, or is feeling some fatigue and stress and whatnot in the work. And then certainly when, if we get feedback about a partnership not going well, we want to talk about, okay, what happened, why, who did you feel like wasn't treating the survivor well, and so that we can follow up with our partners. So there's a lot of good data that can be found in here. Yeah, and then I wanted to move on to the feedback from survivors, so I'll give it back to Sydney so she can talk more about this.
Yes, so along with having our sexual assault advocates complete a feedback on accompaniment for themselves, we also really, really want to, when it is appropriate and trauma-informed, to offer the survivor to give feedback on us, and that includes the forensic nurse, it includes our advocacy, and it also just kind of includes things about their experience. What was the space like? How did you feel in the space? How did you feel, what was the difference in when you came here and when you left? Did you feel a little better? And then do you have what you feel is necessary to start your healing journey once you leave us? So kind of those big, more macro questions. So what we tell the advocate to do is after every single accompaniment, kind of when you're winding down and it's to the end, to go and either use our Chromebook, or if we're at a hospital, to pull up the survey on their phone, which is all linked, and the advocate does not have access to it once the survivor clicks submit, and they let them know that, to give honest feedback if they feel that they are willing, or if it's something that feels good to them and right. Because again, we want to always really reinforce reestablishing autonomy with the survivors. We don't want to force a survey on them if they're not feeling it. But it is our practice that we always offer. There is a caveat to that. And that is what Ashley was saying, how data can be a little biased sometimes. And I will tell you when this happens, and I will also give personal experience because I've done an accompaniment where I had to opt not to give the survey. So we instruct our advocates, when you're in a very difficult accompaniment and it seems like it is not in the survivor's best interest to even be asked to take the survey, if they are they're in emotional distress, if they're feeling super, super tired and they're kind of falling asleep and not really able to really kind of consent to take the survey. At that point, we need to call the accompaniment. We're not going to ask them for feedback. We're going to get them into a safe space where they can heal and kind of do what they need to do to get back and start their healing journey separate from us. An example of that, I was working with a survivor, and we had been going through the entire accompaniment. They were there with their victim service person, And it was a very long interview process. And after the interview process, they were really starting to feel antsy because they were very, very tired. And the forensic nurse went to go and do their set up the kit. And I was speaking with the survivor, and all of a sudden they were just like, I need to get out of here. I need to get out of here. I don't want to do this. I need to go. I said, are you sure? And they said, absolutely. And we always preach informed consent 100% of the time. And so when they were trying to like book it out of there, I checked in with the nurse and I was like, I'm not going to give her the survey if you don't think. And they were like, absolutely not. So in that point, it wouldn't have been trauma informed to stop and be like, hey, can you provide us feedback, when it was that person's goal to get out and to rest and do some healing on their own. So in that moment, we wouldn't ask. But as I said, I checked in with the forensic nurse. So we tell all of our advocates, we want this data, even if you feel like it was a bad accompaniment, the person didn't have the best experience, we're always asking for that feedback because we want to grow. We want to have the system as a whole grow. So we're always having them ask. The only time that they're going to mark that they didn't offer the survivor that feedback is when they've looked at the nurse, they've coordinated, and both of them come to a mutual decision that it is not trauma informed for us to offer that feedback. Do you think I covered everything?
Yeah, I think so. Yeah.
Cool.
And I will point out too that we do have questions, as you can see on the screen, in both English and Spanish. If we had a survivor who didn't speak one of those languages, or it's possible that we may have survivors who aren't necessarily literate, then it might not be as accessible to people. But so those are other biases that could come into play. And so, as Sydney said, when we don't give it out, we do take into account that the feedback that we're getting is from people who may have had a more complete experience with the forensic nurse or the advocate. So we know that this isn't perfect data, but we do hope that we're getting some good information. And I do see that we have a question of, do we have the feedback form available in multiple languages? We only have it available in English and Spanish. And so it's just like you see on the screen, the question is in English, and then right after it, it's in Spanish. So unfortunately, we don't have it translated into other languages right now. So that's definitely something that could be a bias in this work. And typically, my understanding, and Sydney can correct me if I'm wrong, but if we did have somebody come in who spoke a language other than English, we would use the language line potentially, if assuming the survivor didn't speak it. So absolutely. So we always have the language line as an available resource, but that's kind of our last resort. If we have we partner with different agencies around, and if we can get an in-person interpreter, we feel like that's the most trauma-informed. But yes, if we do not have in-person, then we will go ahead and use a medical language line, and the forensic nurse usually coordinates that because it has to be medically approved and all of that good stuff. Yeah, and so we're definitely missing feedback from certain groups of people, and that's just something we have to take into consideration. I do think if we had a group that we had a lot more speakers of a particular language, we would likely add that language on. That's just not currently the case. And one thing I did want to say about this is a good example of where we've gotten feedback that we didn't necessarily think of, and might not necessarily be what everybody would have liked in terms of feedback. But one example is that a survivor, actually multiple survivors, gave us feedback through this form about how they really wished we had cigarettes, because for anybody who's ever been a smoker, you can understand that because smoking is a habit, and you do have both a physical addiction, but also because it can have a calming effect, people who are used to smoking cigarettes, or even who don't normally smoke cigarettes, might see that as something that would help calm them. And because we want to be trauma-informed and not judging people's choices, especially in the aftermath of something that nobody asks for, we want to make sure that we are able to give people what they're needing. So that was some really good feedback, because people don't necessarily plan for an exam, and so may not, if they are a smoker, may not have cigarettes on them, and if they aren't a regular smoker, may not have them. So that was something we weren't expecting. And like I said, we don't necessarily encourage smoking as a healthy habit, but we also don't want to question people's choices, because we try to be strengths-based and like I said, trauma-informed. So as we were talking about the advocate responses, for those who weren't satisfied, we got some feedback that sounded like the exam was really hard, but we got really very positive feedback from survivors. And I was surprised when I was running this data, because first I went through and read all of the advocates' feedback, and I was feeling really bummed about life after reading all of those, because I went back through something like 3 years of data. And then I went and I read the narrative responses from survivors themselves. And just another note there, we look at both the quantitative feedback and the qualitative feedback. So we report on all of these things and we look at all of these things. But the qualitative feedback is really helpful. And I think sometimes when we're talking about data, many of us can kind of get focused on that quant side of like, this percentage of people said that their advocate explained their unique role as the only first responder they have confidentiality with. But we kind of neglect the qualitative data that's in the comments. And so what I ended up doing is taking, I'm going to actually skip ahead, taking the words that people put in the comments box, and I made sure all of it was de-identified and didn't have anything that could identify somebody, and most things were just sort of comments that you would see on any survey you or I might fill out, like the hotel was nice or whatever. Not that we have a hotel, I'm just giving an example. And I put it in a word cloud generator, which takes the most common words and makes them bigger, and then takes the other words and makes them smaller. So this is the word cloud that was generated from the comment section under the advocate feedback portion of the survey that we give survivors. And so as you can see, some of the biggest words were comfortable, helpful, help, kind, supportive, amazing, understanding. And then if you see any names on here, these are names of advocates. And same thing with the next one, which is for the nurses. But we then took, because again, we want to be learning and sharing this information and acting on this information in multiple ways. So the thought was to print this out and put this actually in Eloise's house, and then also maybe make thank you notes out of this for advocates. But certainly it got shared with advocates and nurses as a reminder that they do great work. And then this one is just the nurse feedback one. So understanding, kind, helpful, nice, amazing. So I was kind of surprised at how glowing these comments were, because I would not have expected such amazing comments. I did want to go back a few slides and just talk about how some of these questions came to be. So initially, the questions were predetermined by funder requirements. So we received some funding from, we received funding from multiple sources, but one of our funders, and this may sound familiar to other people on the line, wanted us to ask about whether people better understood their rights as a crime victim and whether they had knowledge of community resources. So we had 2 questions about that. And while those may be helpful in some ways, I know if I were asked about whether I understand my rights as a crime victim immediately in the aftermath of an assault, I would be thinking about, oh gosh, I am a crime victim, and like, what does that mean? And all these things. And I might find it a little odd to fill something like that out on a survey. So we still ask because it is a requirement for us. But we started thinking through what else could we be asking that would help make sure we're providing quality services, and also that we're getting feedback on how to improve. And so we added some questions that would be more meaningful to the program as a whole. So for example, my advocate explained their unique role as the only first responder with confidentiality, because that's such an important thing that we include. And then we have, as I mentioned, we have questions about both advocates and nurses. So my nurse explained my options in a way that I understood. We asked them if they feel better now than when they got there, and if they feel like they have what they need to begin to recover. One thing that I really want to point out is that we, in terms of thinking about what kind of outcomes we're looking for, we really aren't looking for life-changing stuff to happen in the process of the exam. We do want people to feel more settled, but we're not really trying to look at the person has healed, because no one heals in a 4-hour, 8-hour interaction with somebody. Wouldn't it be great if that was how it works? But not yet. Healing is a journey for all of us, and all of us are potentially healing from multiple things at any given time. So we're really trying to stay focused on the specific things that we do hope is changing. So like I said, if they feel better now than when they got there, and if they feel like they have what they need to begin to recover. And also just kind of going back, when we first opened Eloise House and added this nursing portion on, that was for the first time the nurses were staff of SAFE, we weren't looking at collecting this information on the nurses. Our first focus was getting the program up and running and collecting the things that we needed for the forensic side of things. So this is something we added on a little bit later once the program had gotten a little more settled, not totally settled. And I think that was appropriate at the time, because as I was talking before with the right sizing, you want to make sure you're adding in things that are appropriate at each step of the way. And we continue to reflect on what's trauma-informed and evidence-based for the question. So as I said earlier, we don't have it all figured out. I think we probably can add or take away or do lots of different stuff with our survey. So I don't think what we do is the perfect way to do it, but we're continuing to learn as we go. The other thing that I would say is one thing I think as an agency as a whole we need to work on is making sure our questions are at a 5th grade reading level, ideally, because we're another example of a survey that is not for this program. We asked something about, do you know more about the dynamics of trauma? And I don't know that if I were asked about dynamics of trauma, I would feel a little overwhelmed by that, even as somebody who's doing this work. Like, that's sort of a big thing to put on a survey that I'm filling out in 5 minutes. So we want to be thoughtful about how we're using those words and making sure it's at an appropriate reading level. Anything you want to add to me?
No, I didn't even think of that. So I think that absolutely a lot of individuals that we see, those kind of words could be overwhelming, and that's a really good idea to think of moving forward.
Yeah. Cool. Okay, so we talked about the feedback. So we do now partner with 2 different external evaluators. We have partnered with the University of Texas's Institute of Domestic Violence and Sexual Assault, and also known as IDVSA. And that really sort of looked at the development of Eloise House and how that came together. And I included a link here. I don't know if we can also put that in the chat, but this link, I think you can also get it from the materials. It should work if you download the Safe Learning Culture TAASA webinar presentation. It should be linked in there, so you can go to it. But, and actually, sorry, I should say, I think right now they don't have the full research information posted yet, but they have a little bit more about what happened. And I'll talk a little bit more about that in a minute. And then we also partnered with the University of North Carolina, and they are looking at longer-term results and whether survivors have a reduction in trauma symptoms. And that one thing that's been really cool coming out of that Sydney shared with me, because I actually hadn't seen it yet, is that they specifically looked at how people felt about participating in the survey, and the results that are coming out of that is that people, for the most part, felt very comfortable participating in this research. So that's a really good outcome, and we're really glad that people feel like it's been worthwhile to be a part of that. Do you want to add anything about how that went?
Yeah, so I mean, there's not a lot to add because we've only done phase 1, which were the initial getting everybody involved in the study and kind of coordinating that. So we are just going to I don't know exactly because I'm not the person that is in touch with the university, but they will be evaluating us and looking at long-term impacts of those survivors. So there'll be different points where they'll check in with us and show us the results. And it does compare our model to other people's models, so it will be really interesting to see if what we're doing here kind of lines up with other people, or what are the strengths of our model and where are some gaps in what we can learn from other people. So we're really excited to partner with them and move forward with their research. And that's about it. And our director of forensic nursing, Jenny Black, she specifically said when we talked to her about how did you decide to partner with these external evaluators, she said, well, I wanted to do it from the beginning. And I think that's a lot of our instincts. But realistically, when the forensic nursing piece started up and when Eloise House started, we really did not have the capacity to be able to partner with
external evaluators in this way. It takes a lot of time. Somebody has to apply for grants to pay for this to happen. Generally, we want to make sure that survivors are getting compensated for their time in an ethical way. We want to make sure the recruitment of anybody who's participating is ethical. So, for example, in the University of North Carolina study, it was opt-in. And so survivors had the option of whether they wanted to participate or not. It wasn't something where they just automatically were a part of the survey. And as Sydney shared earlier, we have a process of rigorous informed consent at every step of the way with any of these interactions. And so that was certainly true of participating in the survey as well. So I'm going to go through a couple of considerations for when you're partnering with external researchers. So one thing to think about is you want to look at the existing evidence base first. So is doing any kind of research, rigorous research like that's going to add something that hasn't already been decided. So, for example, like with shelter for people who are leaving domestic violence, violent relationships. We know that shelter is absolutely life-saving. We don't necessarily need to do a study on that. But with Eloise House, we felt like doing this off-site forensic clinic is still relatively new in the field. There's not a lot of research on it. And so it wasn't only helpful, hopefully, for others to be able to see this research, but really important for ourselves to make sure that we're very aware of what's going well and where, as Sydney mentioned, where some of the gaps might be, because that's something we need to consider. As I mentioned, we really needed to think about staff capacity and cost because this does add additional time. So, for example, with the research we did, the partnership we had with University of Texas, that required staff to have meetings with the UT staff. And then with the UNC study, our staff has actually gone out to University of North Carolina to meet with the researchers there. So that's a big time thing to consider. And when the program first started, Jenny was probably working 7 days a week. And so the idea of flying out to North Carolina to talk about a research study wasn't really in the cards at that point. I think it's really helpful to establish clear objectives with any research partner and some ground rules. So one thing I really appreciated about the UT study, which I actually got to be a part of some of the conversations with that, was that we set some ground rules from the beginning of how we wanted to work together. One thing that was hard about that research was they used a model that made the study a little bit more organic. And so they let us drive a lot of what we were wanting. So Jenny really liked that because she basically said to them, I'd love to tell you what we do, and I'd love you to tell me, show me some of the things that align, some of the models that align with what we're doing, so we can talk about it in a way that aligns with what else is already out there. And so they were really receptive to that. And that sort of gets into make sure it's the right partnership. So we feel really lucky to have the Institute for Domestic Violence and Sexual Assault in Austin. And we feel lucky that they've been willing to partner with us because they really approach this from a trauma-informed angle. And so they, not trauma-informed just in terms of survivor interaction, which is definitely true of some of the other projects they've done with us, but also just in terms of they realize that staff are doing a lot, and so they try to be very reasonable in what they request from us. One thing that I would also say that I don't have as a tip on the slide is what can happen with partners who have not worked with nonprofits before, especially, or even if they have, sometimes this can come up, is people who go through degree programs, in advanced degree programs, you're taught the perfect way world most often. And those of us who do direct services know it's not a perfect world, far from it. And so sometimes if you're working with a partner who doesn't realize how hard it is to collect data, how limited we are in knowing what data to even collect, how limited we are in terms of having staff capacity to be able to look at that data, because if you're a 1, a 2, or 5 person shop, it's not necessarily, you're not going to have a dedicated data person, certainly. We feel really lucky that we do have that. And it's not that you have to have that in order to do some of this work, but you do need to make sure you're working with a partner who either already understands that or is really wanting to understand that, and that you can be really upfront if they say, I want these crosstabs, that they're the kind of partner that you can say, I don't know what a crosstab is, and like, I don't even think we can generate that for you. So I think it's really important to, again, be really clear about the objectives and ground rules, and have a partnership where you feel like you have control in the situation. And I think one of the ground rules that's probably good for our work just in general is making sure we have shared power in these relationships, because that's hopefully the world we're trying to create in general anyway. And I think sometimes when we're working in academic institutions, there are really clear power delineations at play. So that's definitely something to make sure you're considering if you go in that direction. And then lastly, just make sure you're not losing the program purposes in the goal of doing this external evaluation. If people are feeling like they're getting away from doing good work, that's a sign that it's probably not a good relationship, and something needs to change, because we don't ever want patients to have a negative experience just because we think researching something is really important. So hopefully that's helpful. Just a reminder, please chat in questions. Webinars are always an interesting space because we want to make it interactive, but it can be a little bit challenging. So we'd love to answer your questions if you have any. Okay, so let's talk about some unexpected results. These come not from any of the surveys that we've talked about, but actually from data that's a part of the forensic information that we're collecting. So the first piece is that we looked at how many non-report exams we have, and so those are exams where somebody does have the exam done, but they're not reporting the assault to police at this time. And so what we've seen is the total percentage of non-reports has gone up year over year. That being said, one thing that's kind of interesting is that our non-report conversion rate is apparently high compared to other settings. And I think I'm going to turn it to Sydney to talk about kind of why our non-report might be higher, and a little bit more, because we keep talking about the rigorous informed consent, but maybe kind of what that looks like.
Yeah, so we always, as an advocate, when we are meeting with survivors, we want them to know all of their options, whether that be like if you just want to get checked out for medical care, that's totally fine. If you are interested in go ahead and doing the kit, you can go ahead and have the kit done. It will be a non-report. You don't have to go your APD, but you always have the choice within, I think it's 2 years. If I'm wrong, I'm so sorry, I'm a terrible advocate. I'm just kidding. But I think it's about 2 years you have that choice to come back and go ahead and change that non-report kit into a report. And I think it really has to do with really laying out all of those options that gives that person the power to decide. And I think that we also have follow-up services. So if the person has asked for follow-up, if they've done a non-report kit, our follow-up person who's doing that can ask them about their choice if they've thought any more of it. So it's just really giving them choices over and over throughout the way, and really just being knowledgeable and letting them lead their own path after they meet with us.
Yeah. The other thing that I would add to that is that we've also changed some of our signage. So we have these sticky signs, for example, that people can put up on the back of bathroom stalls that talk about how they can access an exam. And so, for example, on there, we've made it really clear that people do not have to report in order to get an exam. And all of that is not because we want people to not report exams. We're not driving in one way or another. We just want people to feel like that's an option. And the reason why we think communicating that is really important is because our hope is the more people who come in to our services, who might not otherwise have come in if they thought that they were going to have to deal with law enforcement. The more people who come in, that means more people who are getting STD prophylaxis and really good healthcare and trauma-informed support in the aftermath of assault. And if they do choose to do the exam, they may convert when and end up reporting it when had we not been as explicit about their options, they may never have even come in for the exam. And now we've got something that can be used in a prosecution that wouldn't have been there before. All of these things that we're saying are our best understanding of what's happening. We can't say for sure that those are the reasons why these are going up, but we have ongoing conversations with nurses. We have debriefs every week, and we talk. Like I said, we have conversations about, hey, we see this going up. Why do we think that's happening? And so that's some of the information that's been coming out of that. And then the other thing I wanted to point out is the strangulation numbers. So we started tracking how many cases involved strangulation, and that's gone up as well. It's nearly doubled since we started tracking in 2015. And we think the reason why that's going up is not necessarily because there is more strangulation, it's because we and police and other partners are getting better at identifying strangulation. So our nurses and advocates get training on what to look for to identify strangulation and how to ask about. My understanding is typically we use the word, have you been choked? Even though choking is actually not the accurate term, what people think of in terms of strangulation, they think of the word choking. So that's another thing that we've tried to improve on. And though we don't, again, it's unexpected results because we don't want more strangulation in the world, but hopefully we are hoping that this is reflecting an actual good thing, which is that we can get people tied with the help that they need. Do you want to add to that?
Yeah, I think just the only thing that I want to add to that is I want to make it really clear that advocates, we're trained in strangulation from a different method. We are never the ones giving medical advice or asking about medical questions. Where the advocacy part comes in on strangulation is how we get the survivor the best care and advocate to other medical providers of the need to really give them the best care and get the scans that they need after a strangulation. So that's really on our part. I just want to make it clear that we're not giving medical advice because we're not doctors and nurses. But yes, so our nurses are always asking those questions and assessing, and we just really make it clear that it doesn't matter if you don't see bruising. That's not something that does not mean that you were or were not choked is the word that they use. But yeah, so that's really, I would agree with you that we are definitely more on the lookout for it over the years.
Great. Okay. Moving on. Okay, so we've done a lot of talking and we'd like a little more interaction. It looks like we have about 33 people on the call. So we just shared a lot of different examples, and we are a bigger agency. We do have more staff potentially than other people might have access to, but we kind of wanted to use these examples to talk through what learning culture and good data can look like. Again, we're not doing it perfectly, so feel free to also point out where we might be able to do more of this because we're always open to learning. But just to review, learning culture is where learning is an explicit part of every conversation. Everyone's responsible for learning, and we have a culture we try to have a culture of failing forward. So where something doesn't go well, we try to learn from that. We try to examine our biases and we try to be as aware of them as possible, though that's a challenge at times. And then we try to make sure actions are taken, that the information we're getting isn't just a conversation, but there's an actual action tied to it. And then good data is where data is used. So we don't just leave it sitting and we don't just sort of say, oh, we have a lot of data, but we actually hopefully use it to an end, kind of similar to taking action. It's reflective of the client experience, so there's client voice in the data, and we're asking questions in a way that's appropriate to clients, so we're getting the best possible information. Data is right-sized, so we're not, data is right-sized in terms of we're collecting information that's within our means to collect, and then we also aren't overburdening ourselves and trying to do an evaluation when that's not appropriate. I also said I would talk about randomized control trials. A lot of people talk about RCTs as they're shortened to as the gold standard, and in the medical world it is the gold standard, but we need to make sure that any data collection and research and evaluation is ethical, and a randomized control trial you never want to do when there's already a best practice in place. So you would never want to withhold something from somebody when there's already a practice in place. So for example, we wouldn't want to do an RCT to see if doing exams is appropriate because we already have some evidence to show that being able to meet with somebody who's trauma-informed in the aftermath of an assault is helpful. So it's, and it requires a lot of time and money. So generally not appropriate. There may be circumstances where it is appropriate, but just wanted to throw that out there. And again, just wanted to refer to the materials. There's that TAASA Tools for Evaluation PDF that you can download that sort of helps break down when it's appropriate, what different levels are appropriate of data and evaluation. And then want to make sure data is credible. So especially that it's not explained away, that it's actually reflecting what's happening. And I think that kind of covers it. So we'd love to hear from you in the chat box. You should, hopefully you can type in some examples that you've heard of these things so that we can get a little feedback from you. So the idea is, when did you hear us talking about an example at SAFE with our sexual assault services of learning being explicit, or a time where we failed forward? So I'll just pause and let people type. Maya also shared with me that one of the callers, Carol, thank you for sharing this, that these data show increasing non-reports with increasing strangulation, which is similar to a correlation with childhood sexual assault, where victims who feared for their life didn't report. And that's a really interesting point, because there may be a correlation there. And that's something that when we shared that information with others, that that was a question they had, was how much overlap is there? And I don't know, because I think Jenny was going to look into that, and I didn't think to ask her that before the webinar, so I'll have to find out if we think that there is a correlation or not. But that would make a lot of sense, that people who fear for their lives, if they're feeling like they can come in and do a non-report, because one thing that we also know happens is that abusers can be members of family, or, well, not members, yes, absolutely members of the family, but can be involved in law enforcement. And so that things like that make people really not want to report. So hopefully non-reports are helping more people get the help that they need. We also had a question, are y'all creating a system to enable wellness and sustainability for survivors? Is that provided with SAFE? Do you want to take that one, or do you want me to start?
With survivors, so we always offer them the ability for follow-up, and basically basically what we do with that is we're just making sure that they're getting the services that they need, whether or not that be with SAFE or externally. If they're opting in for that follow-up, we are going to speak with them, and after they've had a couple sleep cycles, to just be like, what do we really do need to get you enrolled? And we do make those referrals, and we try to keep them as in services as they want, and we're there for a resource for them for sure. And once we have the case management set up, then there are frequent check-ins. But that kind of,
yeah, I think I'd just add to that because we have other services available, so for example, we have our shelter on site and we have counseling services. Like Sydney was saying, if somebody, for example, isn't safe to go back to their house that night, they can, sometimes if we can make it work, they might be able to stay in our shelter on site. And if they are in such high crisis that they're needing some crisis stabilization, we can talk to the counseling program. We typically have them go through the same process that we have other people go through to get into counseling, but we can kind of flag as hey, this is somebody we're really concerned about, and even if it's not presenting that way, if there's an opportunity to meet with them and do the crisis stabilization, that would be really good. And then I also want to add, we do have a program that's specific for survivors of trafficking, and so we do try to connect people with that program for ongoing care with an advocate there, and those advocates have, because they're working with other survivors, in some cases they're survivors of trafficking themselves, they can get more focused help, because that's such a specific form of sexual violence and often an ongoing situation. So hopefully that answers the question. Okay, so we'll skip past the examples and having people share what examples they heard of these things. Are there any other questions? I know we threw a lot out there. And Maya, I don't know if there's anything that you would want us to add as well, or if there's anything you want to add that you've seen kind of statewide about these things.
I really appreciate y'all really talking about like what's good and appropriate data. And I think sometimes the tendency is that you've got to go really big or do nothing. And I love the idea of really just starting with what's small and doable and does right by the folks that you're trying to serve. So I really appreciate that kind of emphasis that not everybody is ready for a research study with IRB and needing to come up with, double-blind studies. So I think just starting somewhere is really important, or even just looking at what you're already doing and seeing how you can improve upon it is a really good place to start, just in terms of developing that culture of learning. So thanks so much for that.
Yeah, and I would just add, I've lived in rural places, and I've talked to a lot of other organizations that have maybe, one or two staff, and I know that maybe hearing all of this doesn't feel attainable in some ways, but like Maya said, the hope in sharing this information is that it might help y'all get some ideas of how to make little tweaks, and that's really what we've tried to do, is just tweak a little bit along the way and just continually improve. None of this happened overnight. Like I said, our advocacy program has been around since the 70s, so this has all taken a lot of work and time and all of that. I'm not seeing other questions in the chat. Thinking maybe we could move to the 15% solutions activity, but if you do have other questions, feel free to put those in.
Ashley, can I ask you, could you share a little bit about your process of like, how often do you review your questions? How do you decide if they're good or if they're bad? What do you decide to throw out? What do you decide to keep or change up?
Yeah, that's a really great question. I think we could do a lot more of that, if I'm being honest. Actually, when I was going over some of the questions and deciding what to pick out, there were some that I didn't pick out to share because I thought, we could do better with this question. So, for example, there are a couple questions. There's something when you're designing questions that are called double object or double barreled questions, and those are where you're asking about two different things in the same question. So an example might be, my advocate was nice and I felt safe. That's not the actual question. I can't remember what it is off the top of my head, but the problem with those questions is you might feel like your advocate is nice, but you may not have felt safe. So we have to be careful with those. I think ours are sort of on the borderline because I think they say things like, my advocate safety planned with me and I felt safe. So I suppose because it says, and you could argue that they're saying yes to both things, but I, in general, am personally a fan of breaking things like that out because you may have safety planned, but you may not feel safe. And that might be good to know because it's possible that if they say no to that question, it's just that they didn't feel safe. Or it's possible that they didn't safety plan, but they did feel safe. So yeah. So anyway, that's kind of an example of something that we might want to think about improving. Are there other examples of how we do that?
I know that when we were talking with Jenny about kind of how these questions have changed over time, that yearly we really look at our impact plans as a program. So Jenny and the advocacy director, Ishel, and our overall program director, Juliana, when they meet yearly, they really do look at that and think, what could we be asking to spot those strengths and our gaps in services? So that's a time where they do go over that. And I think that's about, I know you know more about impact plans than I do, but it's about annually, I would think so.
Yeah, so we do, the way we set our objectives for the year is we have what we call impact plans, which essentially is people revisiting their logic models, but it's a sneaky way to do it, because if you say revisit your logic model, who wants to do that? But we tie it to the budget process. So when people have to submit their budgets, we take a look at their impact plans. We do try to have conversations about things that could change at that point. One sort of piece of the culture of the agency is each program historically has had the ownership over what questions get asked, which is both great and challenging, because the programs know their program really well, but they don't necessarily know what other programs are asking. So one thing we're trying to do right now is figure out some questions we can ask across programs, so we can see maybe as people move through our programs, how things are changing, or are certain programs more effective at one thing than another, and do we want to say, if this person is wanting to work on this thing, that we send them to this program because of that. But yeah, I think there's both opportunity to improve and things that we do on a regular basis. I guess the other thing I would say is that as we're thinking about the process of trying to find some standardized questions, we are trying to do literature reviews, and we're taking some suggestions from UT as to UT's Institute for Domestic Violence and Sexual Assault. They provided some suggestions in the study that we did with them, and I think they're going to share the evaluation publicly through that link that's in the PowerPoint. So when that gets shared, sort of towards the end of that document, there are a bunch of different tools that might be helpful, and hopefully other people can access that as well. So yeah, there's both good and bad, and like I said, we're continuing to learn as well, which is the point. So yeah. Okay, I'm going to move on to the 15% solutions, but like I said, if there are other questions, please feel free to chat those in, or Maya, feel free to chime in and ask. Okay, so the idea behind 15% solutions, this is from a bunch of different activities that are called Liberating Structures, and the website for Liberating Structures is below. The idea of these activities are, I like to explain it as, they're ways to make meetings less boring and help people think outside the box. So typically you would do them in an actual face-to-face meeting setting, but we're going to try one not face-to-face. So this one's called 15% Solutions, and I like this. I try to do this when I have team meetings with my teams. I try to do this with my teams at the end of every meeting. Not every meeting, but our monthly meeting. So the idea is, based on what you heard today, what is a 15% solution for creating more of a learning culture and or collecting good data at your organization? So take a minute to think of a 15% solution, and I haven't said what that is yet, I realize. It's basically a 15% solution is a small win where you have the discretion and freedom to act without more resources or authority. So, for example, we often think of 100% solutions. So we think, I want to fix the world so that there's no more sexual assault, and I am with you on that. But that's not within my control, authority, or resources to do. So I need to think of something that's a little closer to me that I do have control over. So an example might be, here's a great 15% solution for me coming out of this. I want to ask Jenny, and also maybe even look at the data myself, about whether there is a correlation between strangulation and non-report. So that's a 15% solution for me. So take a minute and think about a 15% solution for you at your organization, and I think it would be very helpful if we put some of those in the chat. So if you're comfortable, put something in the chat, because one thing that's really nice about 15% solutions is once you hear other people's solutions, you start thinking of more solutions for yourself. So yeah. And it could be as simple as, I'm going to have a conversation with a colleague about how they collect data at another organization, or I'm going to have a conversation with somebody I work with about how I want to make learning more explicit part of every conversation we have, or something like that. So I'll give y'all a few minutes to go ahead and type those in.
So thank you, Letitia. It looks like Letitia shared that she wants to have a conversation with her supervisor about implementing this culture of learning, which is very exciting to me. And let me do a shameless plug to everybody here that my job is Director of Learning and Evaluation at TAASA, and it's literally my job to support you all if you're wanting to create a culture of learning. So please feel free to reach out to me. I'm sure Ashley's happy to field questions as well. So know that you've got support in that.
Absolutely. I am really hopeful that people can walk away from this with some actionable items. And again, like I said, the reason why I really like this activity is because sometimes it can feel overwhelming to hear a lot of different stuff, but really the goal of all of this is just making small changes along the way. And so grateful to Maya for being a resource. And yeah, glad we could share. Since I'm not seeing other comments, I will just move on and just say that if you do this 15% solutions in person, the way it works is you have people on their own for a minute identify 15% solutions, which again are just small wins where they have the freedom to act without resources or authority. And I think sometimes we forget what authority we have. So definitely that's a good thing to do to help remind us of the things that we do have control over. And then if you have a bigger group, depending on the size, you can have people pair up in groups of 2 to 4 and take 3 minutes per person to share their solutions. And then they can group members can give each other help on their 15% solutions or give ideas. So that's been helpful in the past. But that's it. We really appreciate everybody joining. We are happy to answer any more questions that come up. Maya, I don't know if there's anything else you want to add to close things out.
No, just a really big thank you to you, Ashley, and to you, Sydney, for sharing all of that experience with us. I think those small baby actionable steps are key in just kind of getting the process started and just being more intentional about what we do and how we think about our successes. So thank you both for sharing all that.
Yeah, thank you. We'll stay on for another minute in case anybody chats questions in, but thanks everybody for joining. Have a great rest of your day, weekend.
Thanks. And in the next couple of days, this webinar will be available on our YouTube channel. So you can look for it there. And if you're a TAASA member, you'll get a reminder that this happened and that you can access it. Also, for those who haven't left, you'll have an evaluation coming to you after this webinar ends. And so please, please, please fill those out because we like to learn about what is successful with our webinars. So if you could give us that feedback, we'd absolutely appreciate it. All right, it's looking pretty quiet, so I'm going to go ahead and end the webinar. And thank you again so much, Ashley and Sydney, for all of your sharing. This was really informative and really helpful. Thank you.
Thanks, Maya.
Thank you.
Bye.
And everybody have a great weekend. It's Friday.